meeting of North Cumbria CCG. Bit of a change in terms of chairmanship this afternoon, but I'll come on to that in a moment. So just in terms of apologies, we've had apologies from John Rush, the lay chair, and Colin Patterson, the acting medical director, amongst other titles. Denise Leslie, a lay member. Peter Scott's an invited attendee, along with Sue Stevenson. And we've also had apologies from two of our GP leads, Helen Horton and Amanda Boardman, which leads me to the point about why I'm in the chair, because our guidance says that if both the chair and the deputy chair are absent or are disqualified from participating by means of a conflict, a member of the governing body shall be chosen by the voting members present or by a majority of them and shall preside. So there's been a bit of a discussion before the meeting that I would chair the meeting, and I'm just looking for approval from the governing body members that can vote that that's okay with them. Okay, that's great. So that precludes anybody shouting out, you don't have any authority, Jackie Weaver, as in the Handford the Parish Council. So we'll crack on at that. So declarations of interests that are in relation to this these agenda items. Has anybody got anything new? No, that's great, thank you. So we'll go on to the minutes and the action log of the governing body of the meeting held on the 18th of March. So for accuracy, page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Nobody got any points of accuracy? That's helpful. We'll confirm those as accurate. Has anybody got any matters arising that are in those minutes that are either not on the action log or not on the agenda for today? No? So we'll move on to the action log then. 7:21. There's one down for Mark and Peter Rooney. Further conversation to be undertaken on equality issues. Is there any update on that?
John Mark here. It's still ongoing, I'm afraid. So there's lots of work going on at various different levels, but that's still ongoing. So we will need to come back on that.
Thank you. And I presume the same we'll have to leave the second one as ongoing because that's down to John Rush. So we'll leave that one as outstanding. And then we've got one on special educational needs and disability, SEND update. The report to be presented at the July meeting, so we'll just pass over that one for the time being as well, if that's okay with everyone. The next two are marked as green. And then the next one is COVID update. A presentation around long COVID be arranged for a future governing body development session, and that's been considered for next month. So again, I don't think we need to take any action. And then the next two are both marked as green. So unless anybody has got any different views, that concludes the minutes and the action log update. So moving back to the agenda, the next item is agenda item 4. It's a presentation by Peter and Ed about the current position for COVID update and the vaccination process.
Thank you. Thanks, Chair. So I've just got a short update just on the issues relating to COVID other than vaccine, and Ed will come in and deal with vaccine afterwards. But Pauline or Lynn, are you able to share the slide?
Yeah, I'm trying to do that now, Peter.
Thank you. Just while Lynn's getting the slide to share on screen, most of the information that is on the slide is taken from the weekly report to the Health Protection Tactical Group, which does become publicly available. So all I'm going to really share here is it largely information which is in the public domain. Lynn, it did pop up briefly.
Yeah. Oh dear, sorry. Oh, hang on. Oh dear, come on.
I always find it gets worse if you get stressed.
Oh yeah, I think.
Thank you, Lynn.
Sorry.
Thank you. We can see that clearly. Thank you. So a few things to summarise. So this is the information here is largely for the week ending the 14th of May, being last Friday. The national R estimate between 0.8 and 1.1, possibly slightly lower than that for parts of the north of England, although potential for some change when I talk about the position around variants, which I'll come to at the end. 0.8 to 0.1 meaning a slightly reducing level of new case rates, but nothing materially changing. Across the country, for England, the rate of new cases per 100,000 population over the 7-day period was 21. For us here in North Cumbria, a better position than that actually, that across the 4 district councils, so Allerdale, Copeland, Eden and Carlisle, the respective rates were between 3 and 15, so 3 being the lowest and 15 being the highest, which compared to, as governing body members will vividly recall, compared to the position a short number of months ago is an enormous improvement and bears testament really to the way in which the public have done so much to adhere to the restrictions that we're all currently living with and are starting to be eased. So a good position around case rates. Predominantly new cases are largely found amongst the younger populations as well. For this 7-day period, during that time, there were no admissions with COVID to hospital, not just in North Cumbria, but I think across the whole of the county. So what you always see is a reduction in case rates, about 10, 14 days later, a reduction in hospitalisation. And then you also, after that, see a reduction in, sadly, people losing their lives. So there were no reported COVID deaths in that 7-day period, which is something really to be celebrated. Though, of course, far too many people have experienced a bereavement over the last year, and we should never forget that loss, really. I nearly, when doing this slide, I nearly put no outbreaks in care and care homes, residential homes, nursing homes. And indeed, in this 7-day period, there were none. And there'd been a couple of weeks where there were no outbreaks at all in care homes. But unfortunately, there have been 2 reported outbreaks in the last few days. Louise may want to add any detail if colleagues have got questions around that. So altogether, that's a very, very promising position locally here in North Cumbria and indeed across the country. In terms of the variant B1.617.2, commonly referred to as the Indian variant. So there's clearly been a lot of national reporting in respect of that variant over the last week, particularly. We do have the benefit as a country that we have exceptional kind of genomic surveillance around the presence of new variants and so on. And there are now parts of the country, particularly in the northwest, especially within Bolton and Blackburn, some parts of northwest London, where this variant is becoming much more present. And although case rates are still very low, is effectively becoming the dominant variant within those areas. The best take on the national evidence, some of us were able to join a call with national colleagues earlier this week, but the best take is that this variant almost certainly is more transmissible than the previously dominant variant, often referred to as the Kent variant. The evidence is still emerging over how much more transmissible it is. So that is still unclear, but almost certainly more transmissible. To date, there is very little evidence about whether this variant has a higher propensity to cause severe disease. There just hasn't been enough time for that to roll through. So there's obviously appropriate national and local surveillance around the impact on hospitalisations and so on. The best take nationally is that the current vaccine programme is almost certainly highly effective at preventing severe disease associated with this variant. The evidence is less strong and will take a bit more time to emerge about whether the vaccine also interrupts transmission from this variant. So in terms of the Kent variant, there's good evidence that people who are vaccinated have something like a 60% less chance of onward transmission of the virus. The evidence is less good associated with the so-called Indian variant. And partly as a consequence of the concern around this, that is why there have been some changes in the national policy position around the vaccine, particularly bringing forward second vaccines for everyone in the JCVI cohorts 1 to 9, effectively people over 50 and those with underlying clinical vulnerabilities, to bring their second vaccine forward from 12 weeks to 8 weeks, which may well be one of the things which Ed will cover in the next slide. So altogether, really encouraging position, appropriate and understandable concern about this variant, and doubtless there will be other variants of concern in the future, but currently a high degree of confidence that the vaccine will be effective, at least in preventing severe disease, if not potentially around reducing transmission as well. Chair, I'll stop there and happy to address questions, etc., unless you'd prefer just to take the vaccine update straight after.
Thank you, Peter. Very erudite as usual. I'm happy to take questions if anybody has. I'm equally happy to go straight on to Ed. Anybody's got any burning issues? We'll just pass on to Ed and then we'll come back for questions then, if that's okay.
Thank you, Chair.
Thanks, Ed.
Lynn, I think I've got a couple of slides. That's perfect. Thank you very much. So since the last meeting of the governing body, the update is we do now have a vaccination centre that opened in Penrith just after the last meeting. It was a week after our last meeting, so on March the 25th. That site is delivering a number of different vaccines, and that also includes the new vaccine Moderna that you will have heard about. So I think as of last week, Moderna was starting to be delivered from Penrith. I think they delivered about 1,000 doses last week. We've now got 5 community pharmacies in North Cumbria: Carlisle, Workington, Seascale, Cockermouth and Whitehaven. We've got a further 3 due to go live, and the reason that we're continuing to open up more community pharmacies is to make sure that we're addressing some of the areas where there's more deprivation or where uptake hasn't been as great. So we're trying to match, in particular, some of the areas in Carlisle with that demand. And then we've got another further 2 that we're looking at that are in the pipeline for 2 remote areas that we've got, but they're a little bit further back in the pipeline at the moment, but they might be coming online in the next month or so. We have had 9 primary care network hubs, and I think I reported last time that the Penrith hub was closing down after it had completed its second vaccinations with cohorts 1 to 9s. That's the over 50s. And the other one is Brampton and Longtown, who had opted out of the programme as well at that point. Since then, Maryport Rugby Club want their rugby club back. So the primary care network are working together. So they're working in tandem at both the Maryport practice now and also at Cockermouth Hospital. So they're working as a PCN. We can still move vaccine around. So when vaccine does arrive, we can move it to some of those more rural practices such as Keswick, Shap, Alston, etc. Next slide, please, Len. So the good news is that we have passed 200,000 first vaccinations as of this week. This data is from 2 days ago. So in total, we have delivered, the programme has delivered over 316,000. That's probably over 320,000 now, of which over 200,000 are first doses. So that's 3 out of 4 people very near. 73% of over 16s have had their first dose. And 42.4% of over 16s have had their second dose. So that means that they've completed the programme. Fantastic numbers, and bearing in mind that there will still be small percentages who either refuse or decline or have contraindications. We are finding that the lower the cohorts, i.e. the younger the people being called in, the more declines we are having. And some of that is related, we think, to people having more flexibility around work or caring commitments for children and others. But we are working with those age groups to make sure that we call as many in as we can. And you'll see by the percentage of the first dose that we're already at 73%. And as of this morning, 34-year-olds and 35-year-olds were being called in. So, you know, there's still a way to go yet, but we're 73% of the way through the first cohorts. And the final slide is just any current issues. So supply over the last month has been relatively low, excuse me, particularly for first vaccinations. That's now starting to open up again. Second doses are still guaranteed. So if people have had their first, there is a supply that will guarantee their second. DNA rates I've already talked about. This slide was 2 days ago when we were calling in the 36 plus. As of this morning, it's the 34 and 35-year-olds. And you'll hear people saying, well, you know, my neighbours, they're only 31 or they're 29 or they're 25, they've had their vaccine. And once again, this is to avoid waste. So as we get through the smaller cohorts, there are less amount of people to vaccinate compared to the amount of vaccine we have now in North Cumbria. So we don't want any vacant slots. We do not want to, we want to avoid waste at all costs. So therefore, we will be calling people in the lower cohorts, and that's absolutely fine with the region and is national policy now as well. So that's the update, Chair. Thank you. Very happy to take any questions.
Thank you, Ed. That's another very positive presentation. Anybody got any questions or comments for Peter or Ed? I've got a couple if nobody else has. Charles?
Thanks, Chair. Just to add to the last point as well, I think in our everyday lives we come across people who've had vaccinations at different times and things, but I think we've also got to be aware of people have their own personal circumstances to do with their health conditions and other risk factors that not everyone's aware of. So it doesn't really help to do the sort of calling people out for having a vaccine when it's not them who's had it. There could well be a very good underlying reason that people aren't at liberty to share. So I think it's just important we remember we get that message across as well.
Thank you, Jones. Carol?
Thank you very much, Peter and Ed, for the 2 updates. I've got 2 questions. One was following up Peter's comment about the recent outbreak in nursing home or nursing homes. It would be good at some point in the meeting, I don't know whether is better, but just to understand, I don't need the nursing homes to be named, but what we're doing in terms of support and follow up from the CCG in terms of you know, because we have done quite a lot of work with them in the past. So just what's happening and any implications on the continuing healthcare team. That's what I'm particularly concerned about. And then secondly, in terms of the trajectory to get to, or you know, up the 73% to whatever we're aiming at, I don't know what that is, 90-something% of over 16s. Ed, do you have any feel of when we're actually going to be calling the 16-year-olds, you know, because it's a immovable feast, isn't it? It changes every week. So I just wondered what the current sort of view was on the trajectory for Cumbria. Thank you.
Do you want me to take that one first, or do you want to
Yes,
take?
please.
So
Please take that one first.
The trajectory at the moment is still, as ever, dependent upon supply. So the more supply we've got, you'll see that we've opened up lots more channels now, where if we get the supply, we can administer it as soon as we can. So we're still dependent upon that. If, and it's a big if and a but, because we don't know, if supply continues as it is, then I think by the end of July we will be in very, very high percentage terms, as in high 80s, middle 90s potentially, by the end of July, if vaccination rates continue as they are at the moment. So if you bring that back maybe 8 weeks, it's not going to be too long. And we've seen in the last week that we've gone through probably 8. What have we gone from? We've gone from the 40-year-olds now down to the 34-year-olds just within the last week. So if that continues to drop at that rate, it's not going to be too long before the 16-year-olds will be called in.
Peter?
Thanks. Just to add what Ed said. So when Ed referred to the vaccine programme being opened up to people aged 34 and 35 last couple of days, of course, they're nationally determined decisions in relation to the national booking system areas. So we will follow the national rollout programme as we've endeavoured to do right from the very start. What Ed's also saying, though, is because we will always seek to never waste vaccine and to accelerate the programme as possible, then on occasions our primary care networks are exercising appropriate professional discretion around introducing slightly younger groups when they can to get through the programme. So I just wanted to remind everybody that these are not locally determined decisions, and we will of course be abiding as close as we possibly can to the national policy framework. In relation to the outbreak issue, I'm sure, Carol, there'll be opportunity for further discussion in quality group, etc. But Louise, did you want to just briefly say something to answer Carol's question?
Yeah, thank you. I was going to comment on that. So, so in relation to the 2 care settings, obviously we're really clear about the route of transmission. Just to sort of reaffirm, it is the incident management group that's currently in place that oversees and supports with obviously local authority and public health colleagues around those outbreaks. As a CCG, we're clearly a member of that group. In terms of the impact in terms of any other staff in the CCG or CHC team, that certainly isn't in place or required at the moment, Carol.
Thanks, Louise. Are you content with that, Carol?
Thank you. Thanks very much.
Anybody else got any queries or comments? I've got a couple for Peter and Ed, if it's okay. One is, I can't quite recall where I've seen this, but I don't know if it's in wider reading or research. I'm sure I've picked up that AstraZeneca was being retained for second doses, and there was a focus on giving Pfizer to the choice of Pfizer to younger people, and it was just about the supply of Pfizer, and was it going to be good enough to deliver our expectations, Ed, really?
The main supply that we're getting at the moment is Pfizer. There are small pockets of AZ, but the vast bulk at the moment, and has been probably for the last couple of weeks, has been Pfizer. And I expect that will continue. So I think that there is a lot of Pfizer within the country at the moment. Okay.
And my last point was, I think this is an excellent effort by everybody involved, but I have volunteered in my part of the world to do a bit of marshalling and helping. And there does appear to be a lot of battle fatigue or tiredness at some of the clinics. And I just wondered, bearing in mind that this isn't going to go away and we're going to head towards the winter and the flu and the third, how were we preparing to make sure that the workforce was properly recognised in terms of the tremendous effort they've made, and if there was anything we needed to do to support them, and what plans we had in place to make sure that it remained sustainable?
I think that's a really good observation. So we are hearing in primary care that people are battle fatigued. It's been you know, 14 months now of going through the pandemic plus winter pressures, etc. And let's not forget that as well as the flu jabs, you know, we'll soon be in flu season, there will be a booster coming up for COVID as well. So there are some discussions at the moment about how that will play out, whether it will be within one vaccination or more likely there'll probably be two with a week apart, which is going to once again add a lot of pressure. Hence why we're trying to open up as many other channels, i.e. community pharmacies, as possible to try and relieve some of the pressure from our primary care networks. The Penrith vaccination site at the moment is probably at half capacity. So it's using one pod. It does have capacity to open up another pod. So we can't, well, when I say we, the region can dial that up as well. But it's a tough one, you know. At the same time, primary care colleagues are being asked to ensure that they are getting back to pre-COVID levels of engagement with patients as well, which is right. But it is going to add pressure onto everybody. I don't quite know what the answer is to that, but I'm happy to open it up to discussion.
Gareth, would you like to comment?
Yeah, I mean,
or have you got a different point?
No, it's on the same point, and I think John, you're very valid. I had actually covered most of it there as well, because it is the bits outside of the COVID vaccine as well. I mean, I do appraisals in the North East and Yorkshire region of GPs, and fatigue is a massive issue at the moment. And I worry about workforce going forward.
Okay, thank you. I don't know quite how to resolve that. I know there's a lot of people with a lot more experience on these issues around the table today, but I think it would be helpful that if at some point we could have something back to the governing body about how that's been taken forward, not least of all the welfare of the people involved, and there's possibly the reliance on volunteers and people like that, because as the shops open and the weather gets better, I think the enthusiasm for volunteering will go down a little bit. So it's something I think we should keep an eye on. But unless anybody else has got any other points on that, we'll move on to the next item, if that's okay. Thank you. I think this is over to... Sorry, I beg your pardon.
Yeah, no, I just thought perhaps actually feeding back to the vaccinating teams, the governing body's formal thanks and appreciation, and we realise it's a long haul, and we appreciate that they're continuing with it.
I think that would be entirely appropriate, Deb. Gareth? Yeah,
I was just going to say, Deb, I think that's a very, very good idea, particularly in light of some of the slightly misjudged, possibly NHS England letters and guidance coming out at primary care in the last week or so.
Yeah, I think another one you're referring to. So thank you for that suggestion, Deb. I'm sure that that will be taken forward. So agenda item 5, Charles, decisions taken under emergency rules for ratification.
Oh, thanks, John. And just actually on the last point, another thing I think to bear in mind in terms of volunteers is clearly at the moment that there have been people on furlough as well who therefore have would normally be working, and hopefully they'll be back to work quite soon. But clearly that also would have an impact on our volunteers. I'm just spanning this item out a bit because unsurprisingly, like I think every agenda this has been on, there have been no such decisions since we last met in this category.
Peter, do you want to say anything?
Apologies, John, because my point was on the previous item. So I
sorry, I didn't mean to rush on.
I wasn't quick enough. It's my fault. So I don't know if you want to just finish this with Charles and then.
No, I'll take that for you. I'd like to take your point, please, Peter.
Just on the previous point about thanking people, recognising people who delivered the vaccine programme, and lots of people do ask, you know, how can we help? How could we show support for this? Well, the two best things that everyone can do, and this is part of the public messaging, is when you're invited to come for your vaccine, please go. Really important. Please go. It protects you. It protects everyone else. And secondly, if it transpires that you cannot attend the time that you are booked, please cancel so that they can offer the slot to somebody else. And that may sound like two very small things, but from a public perspective, the best thing people can do to show their thanks and respect for people delivering the vaccine programme is go when you're called. And if you can't go, if something comes up, if you have to go to work, whatever it may be, please cancel your appointment and rebook so they can offer the slot to someone else.
Thank you, Peter. That's very helpful and very pertinent. I'll close that as item 4. On 5, the fact that we haven't got any decisions taken under emergency rules is as valid as not having any, is as valid as having some. So we'll report the fact that there have been none and move on to the next item, if that's okay, which is the Chair and Accountable Officer report. Are you taking this, Mark?
I am. Thank you, John. Thank you. So just a couple of things from John and I, or from the Chair and I, to report. Firstly, as everybody I'm sure is aware, that we are in the position where we're waiting for the NHS White Paper to go to Parliament. And that process still, as we remember, proposed national timelines of new ways of working to be in place by October of this year, and for those new ways of working in statutory form to be ready to go from the 1st of April 2022 next year. We are still waiting for the White Paper to be read in Parliament. We understand at the moment that that first reading will be sometime in June and the second reading will be sometime in July before recess. And we would then naturally await NHS guidance to come towards us in a formal sense to give us an indication about the detail of what we need to put in place. We are, as I say, waiting for guidance. We expect that to be guidance about what the ICS needs to be and how it needs to be constituted. We would expect something around finance. We would certainly expect something around the HR processes, not least for CCG staff, but also we are expecting something around data and data architecture, which is probably a little bit out of the ordinary, but we expect that to be particularly in respect of approaches towards the management of population health management issues. We have been talking to community groups and partners about the changes that are being planned, and part and parcel of the work that we are doing, and certainly all CCGs are doing across the North Cumbria and North East region, are looking at our current plans as part and parcel of our planning processes, but also being very clear about the priorities that we want to make sure that we have delivered throughout this year for the period of time that the CCGs are in their statutory existence. As you can imagine, there is a huge amount of work going on around that, not least the development of our own plans and approaches and what we need to do. And part and parcel of that will, of course, be how we shut down the CCGs and innovate our statutory responsibilities to ICSs is the expected direction of travel. On a very separate point, recovery plans as we move out of the current phases of COVID and we are turning our attention to recovery. Biggest areas of focus are expected to be on diagnosis and elective work. Clearly, the pandemic process has stopped a lot of that work, and so we are now working in our place-based areas such as North Cumbria, but across the whole of the ICS to understand how we do this in our particular areas, but also how organisations potentially across boundaries can help one another do that. It's a focus generally for us in terms of the direction of travel. It's a very clear focus in terms of the detailed planning that's going on. And as I said, that's happening in lots of different levels, not least at an ICS level as well. Just thinking about improving patient care, and one of the things that I think has been a real success for us in North Cumbria, working with partners across the whole of the system, has been in terms of the Home First work. So a huge amount of work, especially at the height of the COVID pandemic, in terms of how we ensured that we got the right flows of patients throughout our system. Clearly, colleagues in primary care, secondary care, in the hospitals have had to deal with massive workloads. And we've had to deal with some really big issues in terms of how we've got people into hospital, how we've got people out of hospital, back to home or back to care home, etc. And our home first work across North Cumbria has been very, very successful in this respect. I think it's been a fantastic example of collaborative working across all of the groups and organisations across North Cumbria. And this work has been showcased in a webinar hosted by the Local Government Association and the Emergency Care Improvement Support Team, ESIST. And I think that's a real tribute and a real vindication of this work, that it's got national recognition. So fantastic bit of work, focusing on getting people home in the discharge to assess process. It's meant that we have supported patients much more effectively moving through the system and moving through services. So really something to celebrate in that respect. And that work will continue on, and those approaches will continue on as we move into recovery. And hopefully that will only help in terms of smoothing the pathways for our public and patients as they access our services in the future. It is also the case that there is a focus on well-being being launched in the North Cumbria area. The start was on the Tuesday, the 15th of June, where there will be a range of speakers and workshops, all focused on things like improving health, improving and developing resilience. So it is very much about personal, family, community health and well-being. You will see that there is a link in your notes that gives you information about that. And I think that this is really important, another step in terms of the ways that we collectively as organisations in the North Cumbria area can support our public and can support our patients in terms of a range of practical tools and techniques to help people enhance well-being. So a really important and very exciting bit of work there. You'll see that we've put something in terms of third sector collaboration in the Recovery College. And the Together We Community Interest Company has been awarded £49,000 in terms of a grant by the Shine Fund to set up a recovery college to support people's mental health and well-being in North Cumbria. So yet another initiative in this area. It'll provide a programme of free courses and workshops, helping people to improve their well-being and recover from mental health issues in particular. They're going to be developed and delivered by peers who have lived through the experience of mental health themselves. So particularly timely, I think, because we are very aware of the impact of COVID on people's mental health, very aware that potentially those impacts will go on for quite some time with people. So whatever ways and means we can find to help support people with those requirements going forward, very welcome. And this is a specific Recovery College initiative that we are hoping will be very well received. We've also got and provided you with details about the Health Mealer. So this is another virtual health and wellbeing event. There will be more than 20 films available, offering advice and tips to people for helping them to tackle very specific problems. It went live on Friday, now available across YouTube, and it's been organised by the Brampton and Longtown Rotary, supported by the NHS and third sector groups. Again, we've put in place the links for you to be able to pick that up. And I think, you know, what we're seeing here is a picture of a lot of different initiatives now coming to the fore, hopefully helping people to deal with health and well-being issues in lots of different arenas. But also, hopefully, there is a lot there for people to be able to pick up on things which are of specific interest to either themselves personally or their families or their communities. I think that's probably all the things that we wanted to flag specifically in this update, John, but very happy to answer any questions if people have any.
Thank you, Mark. Very comprehensive as usual. Any colleagues, any questions, comments for Mark? I suppose it was that comprehensive. There aren't any questions. I've got a couple of comments though, Mark. I mean, I think we mentioned the sustained effort of colleagues delivering vaccines in the various hubs. I think it's also important to recognise the sustained effort of staff in the wider system, but particularly in the CCG for their efforts over the last few months, and more particularly what we expect of them over the next few months, because I think I've heard colleagues around this table say that the CCGs have got something like 214 duties and responsibilities which will need to be safely navigated, as you commented. But we've also got to focus on the post-pandemic recovery of services and the maintenance of patient safety. So there's a big agenda for a declining organisation. And again, I suppose my question to you would be about how do we maintain the morale and the support of the workforce to take those issues forward?
So it's a really important point, John, and I think we need to acknowledge and thank staff for everything that they've done so far. We do that in virtually every conversation that we have with people, because it is really important to remember what people have done, the time, the effort, and the skill that they brought to dealing with the pandemic in North Cumbria, and we have had some very challenging times here. We also have to remember the fact that people have been dealing with their own personal and family circumstances in terms of COVID as well, which, for some people have been very difficult to deal with. But it's also the case that our agenda doesn't feel like it's slowing down. We're dealing with recovery, but we also need to deal with how we work through the changes to the system, how we make sure that we get our staff to the right place in the system moving forward. But it's also this issue that we've got about making sure that we are very clear about our priorities while we are still here as an organisation. I think it's important to reflect on the fact that we still are here. We still do have our responsibilities and our responsibilities on behalf of our public and patients, but we also need to make sure that we are going to deliver what we expect to do this year and ensure that we lose as little momentum as possible as we move towards the new ICS organisation, who will pick up the responsibilities that we will continue to deal with while here.
Thank you, Mark. Deb?
Thanks, John. I just wanted to sort of draw together the start of what you said, Mark, about the white paper and the Recovery College. And we've got an exciting future ahead with the partnerships with our third sector and community. And I think the Recovery College is a fantastic example of what the future will look like using the resources that are in the community, supported by the health and other statutory services. And it sort of excites me for the future.
Thank you.
I'll get myself off mute. Thanks, Deb. Anybody else wish to comment? I don't wish to leave it lingering. I'm trying to stick to time because I know people have got other meetings to go to, and I think I'm about on time. So if we could go over to the annual report on the learning disability mortality reviews. Leader from Louise, please.
Thank you, John. I've actually asked Nikki Truitt, who was one of the key authors of the report, to present that, if that's okay. So I'll hand over to you, Nikki. Thank you.
Thanks. Hi, everybody. I'm just going to attempt to share my screen and see if everyone can see the actual present. That's brilliant. Thanks for that, Louise. So this is the third annual report that we're presenting for the learning.
Nikki, sorry, it was already on screen, and when you've shared your screen, I think we've now kind of got it up twice.
Okay, so should I take it off my screen?
I'm not sure, but I think it was already there.
Can you see something on the screen now? Because I've taken mine off. Okay. Not sure how we can help with that then. Is that, oh, no, let's try again.
Yeah.
So I can see that on screen. Is somebody else sharing it? Is Lynn sharing it? Okay, I'll just tell Lynn to scroll down then. Thanks, Lynn. So as I was saying, this is the third report, annual report that we're presenting for the leader scheme. So that's the learning from death with people with disabilities. As you know, it's actually a requirement of the NHS long-term plan that we produce this annual report for you. and it's really a summary of the work that's been done for LEADER over this past year. But the long-term aims are to reduce inequalities in this vulnerable client group. And as I'm sure you'll be aware, they can actually die on average 20 to 30 years earlier than the general population. So, so thanks. Yeah, so we need to be on slide 2. That's right then. So as you'll see from reading the reports, I'm sure you all have, it's very different in style this year to ones that we've normally tried to present to you. And we've had a lot of help from our wonderful comms team to make it a lot more visual and accessible. So thank you very much for them. But it's much more easier to read, I hope you'll find. Having said that, we will still produce an easy read format for this report to go on our website as well. And that's obviously a requirement for us to do too. But this year we're celebrating the fact that this is actually the first, and I think it's the first across our region certainly, that is co-produced. So we've done this work in combination with our patient first advocacy-based Confirm and Challenge group who work with us on the LEADER work, and they've been great. I mean, it's been a slower process. We've had to start earlier. So that we can get the meetings with them and fully engage with them and fully explain the issues to them. But their input has been invaluable, really, in terms of giving us that unique perspective that we have. And obviously, I couldn't go any further without thanking and acknowledging all the hard work that's gone into not just this report, but all of the work that's gone into LEADER this year, with contributions from all the reviewers that have worked hard, and the providers and the clinical staff, and really everyone that's been involved in the service improvements that we've done this year. If you move to the next slide, Lynn. Our focus through the co-production has been on making this report a focus on people. So I really, when you're looking at the report, would urge you to try, if you can, to prioritise reading the pen portraits. So these are to try and give you an insight into the people behind the data. So every single number that we quote in this report relates to a person who's lost their life, an individual who's loved and lost and missed. So we just really wanted you to see the people behind the data. And if you look at some of these examples, obviously the names have been changed, but it will give you a flavour for some of the things that we're reviewing. We've also tried in the report to give you some idea of some quotes from the actual reviewers themselves and from the family members and the clinicians, and you'll see those in the report. And it's really just to try and where we can to try and bring it to life for you, rather than it just being a dry reflection on data. Next slide, Lynn. So in terms of the data and the reviews, there's a whole section on data that I'm not going to go through in detail. There's some interesting things in there for you to look at, but I would offer a health warning that whenever you're looking at data with such small numbers, it's hard to actually extrapolate upwards. Remember, we do have small numbers of North Cumbrian leader deaths, and we had 35 this year. So obviously, to look at that, you need to be careful what you're sort of comparing it to. But I think of note in terms of the data is that we only had 3, I say only because every one is important, but we had 3 COVID deaths directly related to COVID this year. Now, if you take that 3 and think about the number, so in terms of our learning disability population in North Cumbria, if you take every one that's registered on every GP register, it's somewhere near 2,000. It's 1,970 people that are registered. So 3 out of 2,000 is what we've been looking at this year. So much better than the national picture. If you do what I've just told you not to do and translate that into the higher levels and extrapolate it upwards, it makes it a rate of 150 per 100,000. And that compared to the national average which is nearly 370 per 100,000, more than double. So we've fared better than the national picture. Also to say, if you look at the report, you'll see that there is 10 more people died this year than they did last year. So 35 this year, 25 the previous year. But I just wanted to make clear that because of the issues that I'll come on to around the closure of the Bristol platform, it has meant that we've had to sort of front end our work, and we've had to do some work in advance. So 7 of those reviews we wouldn't have been reporting to you until next year. They weren't due to be done until June, and we've done them early this year because of the closure of the platform. So that's given us a little bit of an artificially high number. So there'll be a corresponding lower decrease next year when we do the same report. I think also of note is that we've been slightly less successful with the hospital deaths this year in terms of preferred place of death. But we're still better than the national figures, but it is something that's one of our priority areas that we do really want to carry on building on. But it's hard to know, again, whether that's due to COVID or not. It's not something that we can really extrapolate. And then overall, again, every year, this has been the third year in a row that all of the age of death remain better than the national level. So people are living longer. And if Colin was on the call, he would definitely comment that some of the reviews he sees in the serious incident closure panel, he celebrates the fact that they're sort of 70, 80, 90, which is, really quite unheard of in terms of some of these deaths, really. So moving on, Lynn. In terms of the themes from reviews, I've been here and talked to you about these same reviews last year, and I think they'll probably carry on again, which in some ways makes you think, are we actually making a difference? But I can tell you that, things like each one of these themes, the number of them occurring as a problem in reviews is getting less and less. So so definitely, for instance, let's say the wrong kind of recording, if you like, in records of cause of death is actually 4 out of the 35 reviews. Same for the sort of poor recording of best interest and mental capacity. That was 4 out of the 35 reviews. The problems with hospital passport were only 2 out of the 35 reviews. So they are coming down an awful lot better. So I think there's been improvements made in all of the themes, and lots of actions gone towards that. Next slide, Lynn. The successes this year are they're numerous. The team have worked really hard. They're clearly listed in the report, so I'm not going to read them all out to you. But I would like to sort of say that we're really particularly proud of our work around sharing learning with system partners and the training events that we've put on and facilitated. We've really taken advantage in this COVID year of the virtual webinar formats, and I know we've reported previously on things like the learning disability primary care PLT that we did, where we had over 250 attendees. So I think we've done really well to get to a wider group of people this year. And I think it's also worth acknowledging, and picking up what I know you've been talking about from what I heard of your conversations earlier, that it's really worth acknowledging it's been a very difficult year, and it's very difficult. We've lost reviewers to the front line, so we've had a smaller team to work with. And as you know, Chris was a reviewer as well, so we've permanently lost his skills. And there's been such pressure in terms of the primary care work and the vaccine rollout that, if anything, I'm really surprised to be able to tell you how many achievements we've had, given that backdrop, really. And it is just it's really a testimony to the hard work and commitment of the staff that have been working with this client group to really prioritise it. They haven't put it on the back burner at all. They've really driven forward with the initiatives and taken it seriously, and it's really meant something to them to do that. So I think that's a good achievement. Next slide, Lynn. So the priorities for next year, again, are really clearly highlighted in the report. So they're there for you. I'm happy to answer questions on them. But the main bit I wanted to draw attention to was really about the new policy and the new platform, because I think that members probably won't be as aware of that. So the new national policy for Leader comes into effect in June, and there will be a transition period to fit in with the new ICS structures. The scheme will still be called Leader, but it will include learning from the lives as well as deaths of people with learning disability, and it will also be extended later in the year to include autism. So that's people who don't have a learning disability but do have autism. We don't know yet the impact of that. I think the national team think it will probably only be an extra 300 reviews a year, but there's an awful lot of scepticism that that's the case. I think it'll be a lot more. So we don't know the impact of that yet. There is also a move in the new policy that they want to create a team of reviewers across the ICS footprint who only do Leader reviews, which is great in terms of prioritising the importance of the reviews, but it's very different to the model that is in operation across North East and North Cumbria everywhere. At the moment, we rely on existing staff to volunteer to do reviews as part of their existing workload, and they're great and do that, but it's an add-on to their existing role. So the problem, I'm sure Charles will pick up straight away, is that there is no way of extrapolating that cost out of their roles, and so there's no money for this new team to be just doing Leader. For me, I'm more interested in the fact that the ICS is a large footprint, and we want to make sure that the learning does pertain to North Cumbria, and we don't want to lose that in the mix of things. So a few challenges for us to look forward to, in not least the fact that everyone will have to be retrained in how to use the platform and the new sort of rules and things. So I'm happy to take questions. I'm sorry if that was a bit of a rapid run through, but I know that you've got a busy agenda and you've all read the report, so happy to take questions.
Thank you, Nikki. I would just like to say that it felt a very personal report. I did read the pen pictures, and I thought that made the report much stronger. And the other point I would like to make is when I first joined North Cumbria CCG a few years ago, I knew little about co-production, but it is quite clear that it's inherent in everything we do in the CCG, and I think that makes it feel stronger. But I'll open it up to colleagues for comments. Louise, would you like to say something?
Thanks, Chair. I would like to add to that. I would agree. I think it's an excellent report. I think it clearly starts to say what we want it to be in terms of accessibility and its actual patient focus, and clearly on learning as well. I know that Sue from Health Watch isn't able to be here today, but I know she's already sent comments again, commenting on the accessibility of the report. Very interesting in respect of the learning and the focus on the local priorities, and clearly sets a benchmark for how we would want these reports to be produced in public. So very well done to Nikki. As I say, I think it's an excellent report. Thank you, John. Thank you.
Carol?
At the risk of repeating everything that Louise has just said, it is an excellent report. I've seen these reports develop over the last couple of years, and in fact, I can't believe it's already come again, this one. And you've done an amazing job, you and the team, Nikki. Thank you. And it's very clear what the actions are. And I think if Mandy was here, she would have some additional comments to make as well. I think one such comment might be that one of the actions is to ensure that we're on top of our game in terms of the annual health reviews, as they have suffered during the last year. And she did report, I think, at the last quality and outcomes meeting that primary care has already really rallied and has been able to meet that 75% target. I think in fact exceed it. So I just wanted to make that point. It's another good news story that even though the action is for the next 12 months, we are already on the case. So thank you very much. It is great to see, and it's I think we're doing well in terms of what we're achieving. It's not just a report that looks good, but we're actually having, I think with the work, a real impact on people's lives going forward. And I'm really support the wider emphasis now on talking to people about their lived experiences and not just reviewing what's happened after somebody has passed away. So thanks very much, Nikki.
Welcome. Thank you very much.
Anybody else wish to comment? No. I mean, I'm sure you refer to Charles and the financial situation. I'm sure Charles will look positively wherever he can, but often he's constrained, much to his frustration in what he can do. But unless anybody else,
John,
sorry?
just to respond to that, I mean, I think clearly that's a financial constraint. If we work on the basis of all the organisations continue to work as they do, and then there's a separate team is created, as Nikki very eloquently articulated. I think it may be possible to do something like this when we actually move to the wider ICS as an actual organisation, because there will be things that currently in all our teams to address those 214 or 41 duties you referred to earlier, John, that actually we won't need to do 8 times in future, but are done in each of the individual CCGs. However, I do just this isn't a financial issue, just sometimes wonder whether for something like this, actually to have staff who do this but have other duties as well, perhaps brings a wider focus and different approaches to perhaps dealing with individuals with a learning disability and also their families as well, that it might become a bit I don't mean this in the wrong way, but almost a bit more of a treadmill sort of focus if you're just doing this all the time. And it will be interesting perhaps to get some feedback from the likes of Health Watch as to what they think about that sort of approach, because I think sometimes we do tend to try and look at efficiency in one respect, but actually we need to take into account for things like this what would be better for the patients, but also what would work better for the staff, because you might get a bit of burnout if you're just doing the same sort of process all the time, of which I would imagine, while we've got some very positive reports, that might not be mirrored everywhere, and it might be it might be quite a challenging role to fulfil if this is all we're doing. So that's just an observation.
If I can just pick up Charles's point there, John, if that's okay. Just to say that we're not actually far off where we need to be in North Cumbria. We already do have one person that's our main reviewer. That's part of her role to do that. So, but the other thing that we do, and I think we're allowed to continue doing, is that we will use existing people as buddy reviewers, because I think, picking up on Charles's point, it is really important that we share some of that expertise, so that we have got a mix of practitioners contributing to the process. So you get a much richer review if you can actually have two people from a different background looking at it. So hopefully we'll be able to bring that to the table as well, and still bring those buddies forward to support the one reviewer that we'll have. With us only having such small numbers in North Cumbria, it's likely that it'll only be about 0.5 of a whole-time equivalent role doing the actual reviewers, but and so therefore we'll be able to add to that role, because this person's full-time, to carry on doing the action from learning. So that will be where we might get a bit more of the real work, and be able to sort of see things through to the end, and the improvements made, to sort of stop some of that treadmill work that Charles refers to.
Thanks, Nikki. Carol, is that a legacy hand?
It certainly is. Let me remove it.
Thank you. So I can't see any other hands, so just like to close the item by asking you to take thanks back to the team for their efforts throughout this last few months, and the professionalism and this excellent report, please, Nikki.
That's brilliant. Thank you very much, everybody. Thanks.
Thank you. So we are asked to note the three things we're asked to do: note the content of the report, be aware of the ongoing challenge, and approve the report. I think John Rush normally likes a proposer and a seconder, so if I could have a proposer, please. Thanks, Carol. Seconder, Louise. Great, thank you. Moving on to the next item then is the financial plan. So it's Charles.
Thanks, John. What I'm proposing to do today is sort of go through some of the wider issues here, rather than the actual detail of the plan, because we had the Finance and Performance Committee yesterday, and we went through, we had a detailed discussion both about this and indeed the wider ICP and or Integrated Care Partnership and Integrated Care System plans. The reason this report's here today, and we are in very unusual times. So in the financial year that just ended on the 31st of March, we worked in what was best described as a COVID financial framework, not just the CCG, but the whole of the NHS. Normally we get funding and such like confirmed for 12 months, and we set a budget for the year. But owing to COVID, and I guess the uncertainty of some of the issues that both Mark and Peter have touched on, in terms of the positivity about trying to get into recovery mode, plus perhaps some of the uncertainties from the, I think we call it the April 21.2 variant. We just had an update during the meeting on that at the moment, and what impact that might have. So for the current financial year, the NHS has a financial settlement for 6 months, and organisations were asked to submit plans for that 6-month period. So the CCG's plan, and this is, people may think this sounds like NHS bureaucracy gone mad, but actually it isn't quite. Is the CCG put a plan together along with North Cumbria Integrated Care Trust as being the two NHS bodies in our ICP, and then that's been consolidated into an ICS plan, which was then submitted to NHS England and Improvement for review. Now, the reason for that, Mark was talking earlier, is about the white paper and trying to do things in an integrated way, rather than perhaps in the past where we've had sort of one organisation doing one thing without any regard to what everyone else is. So in the big picture, it's a good thing. It's trying to get us all to work together, but at the same time, while we exist as statutory bodies, we still have our own responsibilities as well. So the reason for bringing this paper here is to ensure for the next, well, I was going to say next 6 months, we've pretty much seen to them already, but the CCG has a budget and a plan that it's working to, so we can monitor our financial performance. Now, the CCG's, the resources for H1, everyone's calling it, which does stand for the first half of the year. It's no more complicated than that. We're set based on the projections for H2 in the previous financial year, based on the period October to December, which all sounds very complicated, but basically, to sum that up, our plan for the first 6 months of this year is very similar to what we spent actually in the second 6 months of last year, because for the work that we do, the world hasn't changed. Most under these rules, at least 80% of our expenditure is fixed. We don't have contracts with NHS providers. We have an agreed amount of money that was set nationally that we pass across to them. So we've just put all the numbers together, and lo and behold, it's not actually much different to what was happening previously. The big difference we're all hoping for during this period is particularly on elective or planned care. The NHS nationally and in North Cumbria starts addressing the backlog of cases that and appointments that need to be seen, and a separate fund has been established called the Elective Recovery Fund for NHS providers to access when they do that activity. So that isn't in our plans, but what is in our plans as part of that recovery is a commitment to meet the mental health investment standard, as we've done in previous years as a CCG, and also some significant new resources to address mental health, because clearly at a national level and a local level there was an acknowledgement that for many years mental health had been to some extent not given the priority it needed to have as a service, and probably this has been compounded by the views that as society hopefully returns to normal, there may well be a lot of people who have issues with their mental health which have been either caused by or enhanced, might not be the right word, but exaggerated by the impact of the pandemic and all the changes to our lives we've got to meet. So taking all those things together, there's roughly in the next financial year, we will be passing across for, if you like, new spend with CNTW around £5 million, and there's also going to be work. We think there's further national money coming on some more community-based services, which we'll be working with the third sector, hopefully, on developing. So even within that context, that there is some considerable investment. The final thing, I think it's just important to say, because as a construct in the main of this COVID financial regime, we're showing a deficit budget, but our understanding is, based on discussions we've had with both the ICS and indeed NHS England in Improvement, is that level of resource that we're planning to spend in that year is sustainable within the financial arrangements that are currently in place. And I think it's very important that is recognised. And also part of that recognition is the NHS at a national level is very clear how hard and everyone has worked, what a tough year dealing with COVID it is, and therefore the sorts of levels of, I call it cost improvements, efficiency, whatever, that we've maybe seen in the past are currently excluded from that regime for those very reasons that was approved by the NHS England and Improvement Board. And as we all have discussions both locally and further afield, it's perhaps it's useful to remind all parties who we might be having conversations with about those parameters. So essentially, that's the position now. We do expect that H2 may be more challenging, but we don't have that detail yet. And I think we would all acknowledge prior to COVID, there were financial pressures in North Cumbria. And as we get more clarity of the way forward, we'll need to properly set out what those are and collectively deal with mitigations to some of those causes. But in the meantime, we still have to function as an organisation, and therefore it's important we have an operating budget for the first 6 months.
Thank you, Charles, for that thoughtful and comprehensive presentation. Has anybody got any queries for comments for Charles? I've got a couple. I think this is a light-hearted one, actually. Charles referred to my lack of understanding of H1. I thought that was swine flu, but I think that was H1N1. But in the 40 odd years I've been in the NHS, I'm used to triple-letter acronyms and abbreviations, but I couldn't have worked that one out.
It's an efficiency.
Anyway,
it's an efficiency measure, John. They've knocked
they've got a
letter off.
So I think that's quite comprehensive. We're required to endorse. We're required to approve this budget or this financial plan. But what we did yesterday, we had the opportunity within the Finance and Performance Committee to query Charles in quite strong detail, which we sometimes don't get the opportunity because of time in the main governing body. So this financial plan or budget has been endorsed by the Finance and Performance Committee, and they would recommend that the governing body approves it. So that would be the first request, that we do that. However, because of the complications of some of the financing leads, some of the financing initiatives being led by NHSEI, it's been approved as a draft, but it may be subject to some change. So the second point of the approval process would be to delegate, if necessary, to Finance and Performance for them to approve any further changes to it, because the danger would be, it would be rather ridiculous and bureaucratic that then we'd be approving a budget for the first half of the year when we next met as a governing body in July. So that's the ask, just for the sake of process, to approve this as it currently is, recognise it might change, but delegate authority to Finance and Subcommittee should it change. I think that was what we agreed, Charles. Yep,
that's correct, John. Yes.
And as John Rush would normally does, could we have a proposer and a seconder, please? Carol, Peter, thank you. And then we'll move on to item 9, quality update. Louise.
Thanks, Chair. So assuming that everybody's read the report, so first of all, we are still noting that we are continuing to develop and align this report from a performance and quality perspective. What you see here obviously is a summary. Clearly, just to note the challenging picture around the recovery. What's included in here, as we've agreed, is the CQC update. And we can see here, I suppose, the significant amount of progress that's been made. To report on the recent NCIC Quality Board that just happened this week, the CQC also noted the significant amount of improvement and positive progress that had been made in the trust. However, in relation to obviously the current potential around the virus and a potential third wave, as well as the recovery, as I've mentioned, identified the position as fragile. We also received an update from the Improvement Director, again noting their work to support the improvement and starting to think about possible exit criteria, but again noting the challenges around sustainability. In addition, on the report, obviously we've already touched on the slight increase in terms of the outbreaks in care homes, and we are currently going through a process to note around a review of that care home group to strengthen and take forward and align much more our work on a business as usual basis in support of the care sector. Colleagues will also note in relation to infection prevention, which we've talked about previously, is that we are noticing that the C. diff cases have started to improve now, and that's been related to the introduction of a new disinfectant for cleaning, but also note there's a CPE outbreak which is being effectively managed within the trust, but has needed a focused effort in terms of that support. And obviously, I think we've already noted previously in the meeting that the SEND update, the full SEND update, will be coming to the July board on the basis that we'd indicated previously that there would be a repeat inspection possibly in the autumn. With that's now been indicated as moving forward to possibly the sort of early during the summer. So again, just in terms of our preparedness and visibility from a governing body point of view, even though CCG members are clearly part of a range of partnership arrangements in support of that. So I'll leave that there, John, if that's okay. And if anybody's got any questions, I'm more than happy to answer them. Thank you.
Thanks, Louise. Anybody got any questions for Louise? Comments? Okay. Carol?
Sorry, I was trying to figure out how to put my hand up and I had to put the actual hand in, to get your attention. I just wanted to make governing body aware that on the 11th of May we had our Quality and Outcomes Committee, and we did actually go through this report in some detail, and you know, Louise has done a very good job of summarising it. The only slight concern I had when I was speaking to John Rush was the SEND inspection, Louise. If it actually happens prior to the next governing body, whether or not we do need to take anything to governing body, you know, before the SEND, when we know the date before it actually happens. And I just wanted to see if there was any clarity on that. Thank you.
So to respond to that, as far as we're aware at the moment, we certainly haven't any clarity on the date, but we do know that there will be a similar report, I think the day before our QOT going through from the council's perspective. So I think in terms of the alignments, that's what we're preparing for. I can see that Peter's hand up, obviously, who is our representative on the SEND board, so he may be able to give us more detail, but that's my understanding of the current position, Carol.
Thanks, Peter.
Yeah, thank you. In theory, the SEND re-inspection could begin next Monday. So but the nature of the re-inspections are that notice is not particularly provided, frequently not. The best indication is that there is every chance that the re-inspection could occur before the end of the current school year. So there was an opportunity a couple of weeks ago for governing body members, so all the lay members and indeed all the executive members would have received this, to attend a SEND stakeholder briefing, and I hope that people took that opportunity. But just picking up on what you're saying, Carol, we have had a previous report on the SEND update to the governing body, but it might be appropriate to share something with governing body members in the next couple of weeks in anticipation of the likelihood of a re-inspection. So if we can do that, we will.
That's great. Thank you very much.
As my signal dips a little bit.
There is another send stakeholder update coming up available as well, which if everyone hasn't got, we can again try and circulate.
Thanks, Peter. Thank you, Louise. I think for the if I slipped and said performance report when I introduced this item, I do apologise. But for the quality update, we're asked to receive for information and assurance. Okay. So if we can move on to item 10, the performance report, it's Charles.
Thanks, John. I'll try and be quite brief for this item. So just to explain to people, as can be seen in the report, a lot of the NHS performance standards are actually postponed owing to COVID. The report here has been through financial performance in some detail, and this is in essence the last performance report of the financial year that's just ended. I mean, there's still one or two things that I think it's worth noting in for the point of view of the meeting. One is to say clearly everyone has acknowledged the huge challenge that there is in getting some of the planned care and the elective activity in hospitals to catch up. We had a particularly large challenge on that issue in North Cumbria prior to COVID, and therefore that's only got to be a bigger ask, and we've touched on that earlier in the meeting. The flip side, there have still been some positives. So for me, the fact that in North Cumbria, every one of the performance standards, apart from the Category 1 average, and was achieved in North Cumbria, and the reason that they have a Category 1 90th centile performance, which the figures worked out, I think it was on it was just achieved on the 31st of March. It was that close, but nevertheless it was done. Is specifically for rural areas where, as we've said before, in North Cumbria, most incidents are more than 8 minutes away from an ambulance station. So unless we had some sort of time trial, it's nigh on impossible to achieve. The big bit for me is we are developing a new performance reporting approach this year, which ties back into the last item that Louise was just presenting, with the teams from nursing and quality, contracting and commissioning all working together to do that. And we're also trying to expand the report so it covers more of the CCG's business than just things that are reflected in statutory targets, because a huge amount of our work, as we said previously, has been supporting primary care, but actually we don't have very much about primary care in the report, and there are other issues like although we're a small organisation, like some of the staffing issues, maybe it would make sense to put in the performance report so we can look at the performance of the whole organisation. That work's currently under development. We expect to have, I'll call it a working draft, to the finance and performance group in June, to test that out, with the intention that the new sort of road tested report comes back in July. And obviously the other factor in that, which does link slightly to the budget, is in terms of trajectories on which we're measuring our performance, those are all being linked to the ICP/ICS planning point of view that will get signed off in early June. So if we are monitoring what's going on, it is important we monitor against the appropriate targets that we're trying to do to give everyone clarity as to how we're doing. So coming more for completeness, because it's performance in what is probably the NHS's most unusual year and most challenging year since it was started after World War II.
Thank you, Charles. I think that's an excellent summary of the performance report. Anybody got any queries or questions for Charles? No? Well, we're asked to note the report, which I'm happy to do. And as you said, I think the fact that it reflects an unusual year and the suspension of a number of targets, it's probably best that we move on to the finance report, Charles, which is again, yeah.
Yes, thanks, Chair. And I do seem to be on a bit of a roll about explaining things and then explaining why it's all different and what we normally see. But in terms of today's finance report, we have completed our draft annual accounts. They are with our auditors for consideration at the moment. The audit committee, I think, is on the 9th of June. So we've got the process then for approval and sign off of the accounts. What the draft accounts show is for lots of things, there were a lot of positives. We were able to show very good performance on paying our suppliers, which, given all the difficulties many businesses have had in the country, that was key. And particularly there, I'm talking about sort of non-statutory bodies and making sure for the likes of the hospices and such like, we were able to get the cash that was due from us to them as soon as possible. We didn't have any capital. We managed within the running cost allowance, so the admin costs, and we did have a deficit, but at the same time, to go back to the previous point, that was based on a plan which was agreed with NHS England Improvement at the time. We moved away from that slightly right at the end of the year owing to some technical issues that were agreed with NHS England and Improvement before they were reflected in the accounts, and we ended up pretty much where we planned to be. Again, a bit like H1, as I was talking about earlier. For the latter part of the year, financial plans were put together reflecting the overall level of, if you like, financial pressure at ICP and ICS levels, and within the context of the North East and North Cumbria ICS at a draft accounting level. So again, everyone has the same caveats as I've just given them our figures. Overall, the position was in surplus. And I think the final thing, just as a point of information, just to highlight the difference, pre-COVID, we had a balanced plan in place for the financial year before this COVID financial regime put in, and up to the end of the previous year, so 31st of March 2020, the CCG was in a cumulative surplus position. So what we're seeing is the results of a different financial regime, which was put in place specifically to deal with a different set of operating pressures in line with what I've just fed back on the performance report. So I think everyone can wait with bated breath to see what the auditors have to say, but hopefully we'll be confirming these figures on the 9th of June.
Thank you. Comments or queries for Charles on that finance report? I've got a couple of points. First of all, entirely support your comment about it being an unusual year and the fact it was a different regime and all the issues that you reflected there. In respect of your final point, awaiting what the auditors said, I've worked with you for a number of years, Charles, and one of the things that they've always said is that it's been a well-produced set of draft accounts with clear working papers, quite clearly explains how you've got to your conclusions, and there's never been a problem in the past, and I don't expect to be a problem this year. There is one question which I should know the answer to. The audit committee, do you want to come back, Charles?
No, sorry, I was just crossing my fingers.
Oh, sorry. I thought you couldn't find the hand up button. I should know the answer to this. Has the audit committee got delegated authority to approve the accounts on behalf of the governing body?
Yes, it has. Yes. Yeah, that's.
And we agreed that at the last
in the
governing
term.
body.
It was probably agreed, the governing body before that, it's been in place for a number of years, that arrangement, John.
Right.
I think it's actually in the terms of reference, yeah.
So just to note that when we meet, we'll approve that on behalf of the governing body on the 9th of June.
Just to say, John, as well, as in previous years, I think before we have the formal audit committee session, I think the plan is to run just a wider briefing for any members of the governing body who have got the time and inclination just to find out a bit more about what's going to be discussed at the audit committee. Clearly, everyone's welcome to join that.
Well, I'm sure everybody is welcome, but, you know, NHS accounts are a bit dry, and given everything that's going on, they might be drawn to other opportunities, but I would encourage them to come if they can.
Yeah.
Thank you. So we're required to note that report, so we'll just note it. I think we're on to item 12, which are minutes of the committee meetings and any relevant updates from committee chairs. So we have the executive committee minutes of the 21st of December and the 17th of March 2021. Any comments about executive committee minutes? Happy to receive them. Finance and performance from 17th of February and 17th of March. We're happy to receive them. And then Outcomes and Quality Assurance Committee, 16th of December 2020, 17th of February 21, 17th of March 21. Are we happy to receive them? And then Primary Care Committee, 16th of December 2020 and January 20th of January 2021. Happy to receive those. Record receipt of those. Then minutes of the wider system, item 13, Cumbria Health and Wellbeing Board, 16th of April for our information. Northern Joint Committee, 11th of March for our information. Integrated Care Partnership Leadership Board, 4th of February. Happy to receive all of those and acknowledge them. Item 14, questions from members of the public. I haven't been notified of any questions from the public on this occasion. I'll just check with colleagues if that's the case. Nobody else is aware of anything. I'm pretty sure that's the case. I'm pretty sure that's the case. I just wanted to check. Item 15, any other urgent items of business? I haven't been notified of any, but if anybody wishes to raise one, I'm happy to take it. No, thank you. And then the date, time, place of next meeting will be 15th of July 2021 at 1300, and again that will be virtual. So thank you all for your attendance. We're not having a part 2 today due to the absence of some key colleagues and the fact that some of the executive have got clashes in their diary. So I'd like to thank you for attending and for your comments and your participation, and wish you a safe journey or virtual journey to wherever you're going next. Take care, everyone.
Thanks, John.
Thanks, John.
Thank you.
Bye.
Thanks, John.
Bye.
Bye.